Nice.
Okay, so welcome to our meeting to talk about the big, beautiful, ugly bill and its impact on healthcare. Our first speaker, who was very involved with El Dorado Progressives, our healthcare work group at one time, principal consultant of the California Senate Health Committee, is going to give a presentation on the impact of the bill on the state. And we are first going to just let Maureen make an announcement, and then we will get going.
So I just wanted to remind everyone, if you haven't heard, a week from tomorrow, January 19th, Martin Luther King Day, and our Placerville celebration and march will be happening. We will meet at Town Hall. Doors will open at 4:45. We have a great speaker, Dr. Takoy Porter. And then other speakers, poetry, music, video, and a candlelight march. So, like I said, the doors open at 4:45. Program will start at 5, and we will be collecting 5-pound bags of masa to benefit La Promesa Familiar, a local food group, food aid group in our area. Thank you.
Thanks, Maureen. So we're gonna get started with our program. We are planning on doing a series of meetings regarding the impact of this awful bill on, well, Black History Month next month, how it affects women in March, the environment in April, workers' rights in May, and then we will have our annual picnic in June. Once the presentation is ended, we will take questions. If you raise your hand, we will call on you. If we have anybody who doesn't have a microphone, put the question in the chat and we will read it. But at this point, our speaker, it is her turn. So go ahead, Jen, and start your presentation.
Okay. Can everybody see? Sorry, I'm having trouble navigating two things at once. Can everybody see the where I work at the California State Senate, we always refer to it as HR 1 rather than the big beautiful bill, because there's nothing beautiful about it. So it passed in 2025, and it has really significant impacts on Medi-Cal. Medi-Cal is our state Medicaid and children's health insurance program. So I'll say Medicaid and Medi-Cal interchangeably, and then covered California, as well as provider payments for both Medi-Cal and abortion services. Some of the elements were implemented immediately upon signing, and some are trickling out. And in fact, some folks think that some of the biggest cuts are timed to happen after the next election. So, you know, do with that what you will. Okay. So starting with Medicaid, in January of 2027, and this is what the state is getting ready for right now, there's a new, it's called work requirements, and we're seeing this in CalFresh as well. And this is specifically for the adult expansion group in Medi-Cal. If some of you remember back to the Affordable Care Act in 2014, when it was implemented here in California, we expanded Medi-Cal to include adults aged 19 through 65 who don't have dependent children. So sometimes they're called childless adults. You can have children, they're just not children on Medi-Cal. That's who this group is. We have about a third of our Medi-Cal, of the 14 million people on Medi-Cal are in this group. And so looking at it, the state is predicting about 3 million could lose coverage. Now, there are exemptions, for certain people with disabilities, for certain counties with really high unemployment. But in general, in order for this group to stay on Medi-Cal, they're going to need to show proof of employment for the month prior to applying. And then in, I believe, 2 of the months in the preceding 6 months when they do a renewal. So one of the things about the Affordable Care Act is it did make Medi-Cal a safety net for people who lose their jobs and lose their health care. And so now basically what this is saying is, well, if you're a low-wage worker and you still qualify for Medi-Cal, or a part-time worker and you still qualify for Medi-Cal, you can still do that. But if you're someone who's just down and out on their luck, then we're cutting you off health care. In addition, for the same group, they're limiting how often, or they're actually adding how often we check to see if you are eligible for Medi-Cal. For everybody else right now, we check this once a year. You are required to report when you have significant changes in income and things like that. But we're just going to add this other check in. And this particular requirement, it's going to cost more to implement this and program this. And if you think of our county eligibility workers who are responsible for making sure that people get onto Medi-Cal and can stay on and keep their Medi-Cal, we're doubling their work for this group. So we're actually just spending a lot more than we're going to save. But nonetheless, the state is right now predicting that about 400,000 people could lose coverage because every time we have to reach out to someone and make them affirmatively do something, people fall through the cracks, mail gets missed, mistakes get made, things happen. And then there's also going to be a limit on retroactive coverage. So a lot of people first sign up for Medi-Cal when they happen to go to a hospital ER because something's happened. They were previously uninsured and some kind soul at the hospital walks them through some of their options. And so then what they're able to do is, rather than the way normal health insurance works, where you sign up and you get it in the next month, in Medi-Cal, you can get on and get it immediately that month, and then say, you came into the hospital at the end of the month and you stayed there for a while, you can actually go back a couple of months. The big beautiful bill is limiting that as well, and it's doing it differently for different groups of people. Another big thing that we have tried in California since the Affordable Care Act expansions is we've really tried to simplify our Medi-Cal program so that we have same rules for people across the board. And ever since this passed with the big beautiful bill and some hits to our budget, we're having to undo a lot of those things to simplify the program. And then further down the road, still yet to come in 2028, we're seeing potential cost sharing for the same group of people on Medi-Cal. They're allowed to charge them premiums and as well as do co-pays for every time they use their Medi-Cal. Now, it has always been federal law that you could do this on a limited amount, but it's never been a requirement for states to do this. California has chosen not to implement cost sharing. In part because the administrative expense of this often doesn't pay for actually doing it. And also because by definition, these people are the people with the lowest income in the state. So they don't have a lot of money for out-of-pocket costs for healthcare, especially since sometimes they're on Medi-Cal because they got sick and had a lot of healthcare costs and they weren't able to keep their job. There's some other impacts that are coming. One of them is reduced federal payment for certain lawfully present immigrants on Medi-Cal. And this is specifically people who are refugees, asylees, victims of trafficking, victims of domestic violence, people on temporary protected status, and humanitarian parolees. Ironically, back when I started working on healthcare, back in the 90s and way before, we used to give refugees more healthcare than other people because it was part of their resettlement into the United States. Now we're going to give them less than other lawful immigrants. And all of these people are people who are here lawfully, who have documentation, but the feds are no longer going to pay for anything except emergency services for these people. So right now the state is in a debate whether in our own state budget, whether we can continue to cover full scope Medi-Cal for these individuals. The governor proposed yesterday that we only give them state-only Medi-Cal. I think a lot of folks in the legislature will be pushing back on that and trying to keep them in full scope Medi-Cal, but that will be decided in June, like the rest of the budget. And then all immigrants have always had access, regardless of their documentation status, for emergency services, including pregnancy services. And so for those services, some of the federal payments have been at a higher rate than they were reduced in the big beautiful bill. So for certain groups of people, the feds were paying 90% of their care, and now they're going to go down to 50% for California. So even though there weren't specific like cuts to immigrants, the state is being put into a position where we have to decide whether we can continue to pay for them. And this is going to also, I think you might hear this from Siri as well, this is going to put extreme pressure on the hospitals when they're not getting the payment for some of these people, because sometimes they're actually the people putting up the state share of money. And then the thing that went into effect immediately was they eliminated all Medicaid payments to specified providers of abortions. This is mainly Planned Parenthood for 1 year. And so if you know anything about Planned Parenthood in California, they are a huge safety net provider. And about 80% of what they provide is other Medicaid services that have nothing to do with abortion. The feds have not paid for abortion, I don't know if ever, but at least since the Hyde Amendment started. So that has always been out of the state's pocket. But now they're saying just because Planned Parenthood provides abortions, all of the other family planning, preventive care, behavioral health care, everything else that Planned Parenthood provides, the feds are going to stop paying for. So there's some additional Medicaid reductions that are really kind of in the weeds, but turn out to be really big dollars for California. Before we get, I'll back up in a second. One is a new provider tax limitation that's reducing financing for the Medi-Cal program. So if folks were familiar with last year's Prop 35 that was on the ballot, it's a way that states use to finance, and not all states, but many states have programs like this where they tax a provider at one rate and use that provider tax to draw down federal funds for the Medi-Cal program. So they have fast-tracked making changes to this program so that we will not be able to draw in as much money as we did before. There's also something called state directed payments, and that's where state tells the managed care plan how much to pay providers. That is being limited. And then there are going to be new penalties or an inability for CMS to waive penalties anytime they find errors that California has made in someone's eligibility. I'll say one bright spot, and this was touted a lot when the big beautiful bill was passed, was the Rural Health Transformation Program, but we need to put this in context. So California did apply and recently received notice that we are going to be getting $233 million a year for the next couple of years to help improve rural health, and it's going largely to workforce and provider payments. But we need to keep that in context. $233 million doesn't really do anything when the total of all those other impacts I was talking about that we stand to lose as the state in Medicaid funding a year is looking like $30 billion a year. So it's kind of a drop in the bucket. I mean, I think some of those dollars will be needed because we definitely need workforce in our rural areas, and we definitely need, provider payments, but it doesn't make up for what a lot of those providers are going to be losing in regular Medicaid payments. A couple other things that happened are the impact on Covered California. There are many immigrants similar to in the Medicaid changes that are no longer going to be eligible for subsidies. There were also a lot of changes to the verification requirements for Covered California that are going to make it harder for people to re-enroll. Covered California has actually done a very good job of just automatically renewing coverage for people, sending them a notice telling them this is what you got, this is how much it's going to cost next year. If you don't like it, come onto our website and make some changes. But that really helps people just stay in their coverage rather than having to remember to sign on and do something. This way they can always make a change if they need to make a change. And a lot of times when they see how much their healthcare is costing for the next year, they realize they need to make a change. But it really just helps to retain people. And there's going to be some limits on how much we can just automatically re-enroll people. And then while it wasn't part of HR1, what they didn't do with HR1 is allowed some of the federal subsidies to expire, which means that some people are going to see a doubling or a tripling of their health insurance costs. Some of this is still up in the air. I think the House just passed a version that would extend the subsidies, but people don't expect that to pass through the Senate federally. So, you know, they still might fix this in the next week or so, but I'm not real hopeful. So that's 666. Oh, hang on, let me get rid of this. Sorry about that. So that's, well, ignore that black spot for a moment. That's about 666,000 people that will lose coverage. So if you were keeping track while I was going through, we had 3 million on the work requirements, 400,000 on the additional renewals in Medicaid. And then we have about 660,000. So we're looking at least 4 million people who could potentially be losing their coverage. In a state of about 44 million, that's not nothing. So, and then I wanted to just contextualize this a bit for what we have in El Dorado. So of the approximately 190,000 people in our county, about 23% are on Medi-Cal. And another 6,500, about 3% are on Covered California. But I think it's a bit of a oversimplification to think those are the only people that are going to be affected, because everybody needs access to the healthcare system and to hospitals. And so when our providers start losing payment for a quarter of their patients or a good number of their patients, they're stressed and stretched all over. So I thought I'd just end this part with, you know, considering we have MLK Day coming up, you know, he had in the letter from a Birmingham jail, his phrase, whatever affects one affects all indirectly. If you think that the state can withstand this level of divestment from our healthcare system and from our public programs, and your healthcare will never be affected, that's just not how it works. Before I moved up to the fine county of El Dorado, I used to live in Los Angeles County, and just seeing how many hospitals closed anytime, you know, the health system got stressed meant that, you know, waits in the ER were horrendous. And we're really fortunate here to still have a hospital in our county. And so there will be impacts, and we're all going to feel it regardless of our healthcare coverage. Okay. So with that, I'm happy to take questions. I didn't want to just blather on forever. I wanted to leave a lot of room. You're on mute, Dawn.
Does anybody have questions? If so, please either use the raise your hand feature or put it in the chat. Anybody with questions?
I'll ask a quick one. Is there any stress what are your expectations for Marshall Hospital and Barton Hospital in South Lake Tahoe? Are they pretty safe and secure financially, or pretty stressed?
I mean, I can't speak directly to their financials, but I know that in my position, I've been hearing from all of the hospital associations, and they're basically saying the sky is falling. So, you know, I think I did talk to one hospital official, and he said, well, I think it's going to take about 3 hospitals to close before the state is forced to do something. And I don't think we're in the top 3 in terms of closures. So that's what I'm banking on. And that to me was just such a cynical but realistic way of looking at it. And so I haven't heard that Marshall or Barton are on, you know, the list of the most at-risk hospitals, but I doubt they're very comfortable in this situation.
Isn't Barton actually moving out of state?
It might be, I don't know any of the specifics on that one.
Okay, yeah, they bought a casino over on the Nevada state line, and a dead casino, and they're actually tearing it down and building a new facility. Okay, Maureen, you have a
Oh, that sounds
question?
familiar. I think I've seen the construction project over there.
Yeah.
Yes. So, I know you probably said this, but this is going into effect in June, July of this year, or when does it actually go into effect?
It's rolling out over a series of time. Like some of the Covered California pieces already took effect. Some will be in the next year for Medi-Cal. The piece affecting Planned Parenthood already in effect. Most of the other pieces are happening next January. So the state is right now doing all the programming that they need to do to get that into effect. And then there's a few pieces that are not happening until the following year. Some of the pieces though that have to do with provider taxes and hospital financing, those things are kind of ongoing conversations with CMS right now, where the state is actively trying to figure out like what they and the providers are going to be drawing down. It's really messy.
Hmm. Ah,
Okay, any other questions?
Right?
I have a question. Hi. So just the other day, the House passed a 3-year extension of the ACA supplements, and who knows what the Senate's going to do or whether Trump will sign it. How would that affect all these numbers that you've just presented? Any
I'm
idea?
sorry, could you say the last part again?
Yeah. How would that, if that goes through, how would that affect the numbers that you just presented in your presentation?
That was assuming that it doesn't go through.
Okay.
Not being too optimistic here since they didn't put it through
Okay.
when I
But it
didn't
doesn't-
vote. So
But that would only affect the Medicaid,
no, that affects
The
the
covered
Medicaid.
yeah, it wouldn't affect
California.
Medicaid, Medi-Cal,
Yeah, that
right?
doesn't affect Medicaid further.
Right.
Thank you.
Okay,
Anyone
do
else?
we have any other questions? All right, well,
There's a hand raised from,
oh,
Melissa
okay.
and Victor?
are they in the chat maybe?
oh, right, yeah.
Oh, no.
Oh,
Oh, right.
right. Yeah, so Christy, if you could just read what's in the chat.
They haven't posed the question in the chat.
Okay.
Oh,
Melissa
okay.
and Victor, can you put your question in the chat and I can relay it?
Yeah, I see it. Any impact on Medicare?
On Medicare?
Yes.
Not at this point, but I think folks are expecting some other changes with Medicare. And we're also frankly expecting another hit to Medicaid. Like I think, you know, the word on the street, we have a lot of the folks that are lobbying us are also lobbying in DC. So I asked them what they're hearing, and they are expecting that, you know, there be changes to Medicare as well as further changes to Medicaid limiting what the state gets paid. I just don't have specifics on that.
Okay.
Is there
Um,
anything we can do?
Oh,
Is there anything that we can do? That's it. The only question I have is, are there any magic potions? I mean, is there anything we can do to help the state? You know, is there
I mean, I think like the one bright spot that I have been hearing is that that folks in DC and the Republican Party is very concerned, particularly about the subsidies. As it turns out, the Affordable Care Act is now popular and folks don't like their health care being taken away. And so like if you saw the House vote, there were some Republicans that broke rank on that.
Yeah.
And it seems like healthcare is becoming kind of the wedge issue that they fear is going to affect them in the next election. So I would do everything you can to make noise and make it clear that yes, this absolutely is going to affect you in the next election. That seems to be, you know, there's only so much we can do about what is happening federally.
This is true. So the subsidies that haven't been extended, they're not the original Affordable Care Act subsidies, right? They're the expanded ones that were put in under COVID.
Yes. Yes, but
Okay.
I think if we, looking at how much premiums have gone up in that time,
Yeah,
and that it did extend subsidies for people at higher incomes who are still not high income, very middle class people.
right.
It extended the ability for them to get subsidies, and without that, there's no
Yeah.
cap on what they can pay.
Right. I remember a situation. I was working as a contractor about 10 years ago. Well, and 12 years ago. 12 years ago, before the Affordable Care Act, I could get a policy through the contract company that was fairly comparable to an employer policy. But the
Mhm.
second contractor thing, when the Affordable Care Act went in, the stuff that was on the exchange was actually pretty expensive without the subsidy, and I was kind of in the bucket where um I made just too much to
Yeah.
get a subsidy, and plus my employer offered a policy that was quote unquote affordable even though it wasn't. So does this actually kind of close part of that gap?
Yeah, and it affects primarily people who are, in their 50s, early 60s before Medicare kicks in.
Yeah,
And people, at the slightly higher income. But I think, if you're earning, say, 80,000 a year, you can't afford 2 grand or 2,500 a month in
yeah.
healthcare.
I mean, it's yeah, you're got a slightly higher income, but premiums go up as you
Yeah.
age. And I remember at the time, my policy for myself and my 3 dependents was about as much as my mortgage payment. So it wasn't
Yeah.
exactly,
People still have mortgage payments and still have
right.
utility payments. So,
Right.
um,
And home
yeah.
insurance payments in this fire district. Yeah.
Yep.
Okay, do we have any other questions? Our other person is logging on, so we have a little more time.
Is Melissa, does Melissa have another question? Or was that the last question? Let's see.
Her
Yeah,
hand's still up.
we do have a hand still raised, but maybe you
Nope.
just didn't lower it.
It's gone.
Okay.
Okay. All right. Well then, give it another minute. Our other speaker is in the process of logging on. So, does anybody have anything to add while we're waiting?
No, I just want to thank Jen for a really comprehensive presentation. It's not a joyful one at all,
No.
No.
but thank you.
Yeah, my job was much better when we were adding healthcare coverage for people, not when we were
Right.
having these tough conversations about cutting healthcare. And
Yeah.
with those kinds of dollars, like 30 billion, it would be one thing if that were the only thing in the big beautiful bill, but I think you'll hear throughout the year that whether it's the environment, whether it's education, whether it's food stamps, whether it's any, there's just so much
Mhm.
that was divested from our communities through this bill.
Well, and so the impact on all of our community health centers will be pretty substantial. I wonder if they'll be able to stay around.
Yeah, and our community health centers are also facing some other problems with the federal government. The federal government is trying to tell them that they're not allowed to serve undocumented individuals at all, and they're very much a safety net for those people. So they're in some ongoing litigation there. They're really being stressed from a number of different directions. So yeah, I mean, when most of their money is from Medicaid and Medicaid money is drying up, I mean, it goes, you can follow what happens then.
Yeah, my daughter works for a community health center. So I'm just,
Yeah.
But the good news is we're spending more money on private prisons and incarcerating people. So don't get me started. That was sort of a sarcastic
Yeah.
observation. Yeah.
Mhm. Yeah.
And
Hey, we're
textbooks
gonna
for
own
other
half the
people.
world, right?
Well, yeah, and it's oil because it's ours.
Yeah.
Well, if we can throw in some sarcasm, did you catch Dr. Oz? Said in the last couple of days, they're changing the food pyramid and recommendations and stuff, and they want us to drink more, or at least they're taking away warnings on drinking. And Dr. Oz was on TV saying, we will be happier because we will be able to drink more. And probably even some of us will be able to work longer, so
Well,
contribute to the
dang.
economy more. It's really
Maybe
quite funny.
maybe they'll legalize drugs and everybody will be really happy.
Oh,
There you
No,
go.
Good Lord.
didn't they just pass the hemp bill or something?
Oh, okay. Our other speaker is
I just
here.
logged her in.
I don't know if I beat you to it or you beat me
No.
to it.
I beat you.
Okay. All right. Well, I
Hey, and I actually do need to leave, so
okay. Well,
thank you,
thank you
everyone.
so much. We
Thank
really
you, Jen.
appreciate it. Great presentation.
Yes,
All
thank you.
right. So, welcome, Siri. Siri is President and CEO of Marshall Medical Center, and we asked her here to talk to us about the impact of the big awful bill on rural health care. So, did you need me to give you co-host? Was there anything you were going to share, or were you
Yeah,
basically going
actually,
to
I do
speak?
have slides. If I could go ahead and share my slides, that'd be
Okay, I am
amazing.
going to make you co-host. And then you can proceed. Thank you.
Okay, just a couple quick things. First of all, I want to be respectful of your time. So how much time do you have for me?
We actually have until 5 o'clock, so basically we'll take your presentation and then questions, and
Okay.
I likely will end early, but we'll see.
I don't know, I could get really wordy. It could be fun.
Well, you can get wordy if you'd like to.
Go for it.
And then the other thing, because I'm going to share slides, and so I'm not sure how many of you I'm actually going to be able to see. So I'd like to make this as conversational as possible.
Mhm.
So if you guys can either use the chat or let me know if you have your hand raised, or I'll try and keep my eye on the chat, but it might be a little logistically entertaining. So we'll just do my best to try and answer questions because I really would like to make this as conversational as possible because I'd like to
Okay.
answer all of your questions.
All right, so people just raise your hands if you have a question and or put it in the chat. We do have one person who doesn't have a microphone, so I know they'll be using the chat.
Okay. All right. I think if I go to share, yes, I can do that. Share.
Okay.
All right. Now, are you guys seeing it in presentation mode or can you see the ones on the slide?
It's in not presentation mode.
Okay, so let me see if I can do that.
It's fine the way it is. It's
Yeah, I mean
How's that?
we can read it. Oh, there we
Okay.
go.
okay.
Okay. We'll try that. And then I can see you guys on the side, so feel free to raise your hand and I'll try and watch chat. I'll try and I can see if people raise their hands, so that helps too. Oh, so first of all, I just want to say thank you guys for having me and including me in this conversation. I do have some background information and some other information to share, but I'm happy to give you the update on One Big Beautiful Bill. I didn't put a whole bunch of stuff in the slides because some of the impact of California is changing very rapidly. And so I wanted to make sure I'm able to give you guys the most up-to-date information, which I'll do as we get to those slides, but it may not be captured specifically because, like I said, things are moving fast. So a little bit about Marshall. This is our vision. We always start with our vision, and we spent a lot of time talking about this. But our vision is really a world where everyone can achieve their highest desired state of health and well-being. And there's a couple things about that I like to point out. Number one, it's a world, so we'd like to be able to influence, like we can't, like send the ripples out in the world. So that was one part of it. And then highest desired is another key part of our vision because that really speaks to meeting people where they're at. Healthcare has a tendency to historically been a little paternalistic, or I am the medical professional, I know better than you kind of thing. And what we're really trying to create is an organization that listens to people, that understands that physicians know they're very intelligent, they know all about their area of specialty, but they don't know you necessarily. And so having that conversation and that open dialogue about what's going on with you, what's working for you, so whether that's your stance on medications or whatever. So really just being open and listening to people. And then well-being is another big part of this, is because we really want people, it's not just that whatever your medical problem is, if you've got, something wrong with your gut, it's broader than that. It's how do we help people live their best life in a way that we can influence that. We're been in the county for a very long time. 1957, it was organized. The hospital started in 1959. I won't go through this other than saying that Marshall's been a major part of this community for more than 65 years. And it was started through generous donations through the community. So back in the day, after World War II, there was this thing called the Hill-Burton Act. And the Hill-Burton Act actually was a federal program that would provide grants to hospitals. So if you raised 1/3 of the money, the federal government would give you the other 2/3 of the money. And then you worked off your federal grant through charity care and other obligations. And so Marshall is an example of one of those Hill-Burton hospitals. And so we, the community, El Dorado County, raised almost $412,000 in a really short amount of time to be able to meet that federal matching grant. And that was what was able to start the hospital. The other thing is the land where the main hospital sits right now is actually donated by Michigan Bar Lumber. So we are proudly born and raised out of El Dorado County with deep roots in this community. We're the only hospital on the Western Slope. We serve about 150,000 people, anywhere from Echo Summit down to the county line, and sometimes even past the county line. We are a level 3 trauma center. And what does that mean for all of you? That means if something bad happens, we're accredited by the American College of Surgeons as a trauma center, so that we have the processes in place to immediately take care of you right away and transfer you to a higher facility if there's something like you need brain surgery, and we can't do that at Marshall. We are independent and not-for-profit, so that's important. So we're not part of a big system. Not-for-profit, people forget all the time. That means that we are a 501c3 charity all by ourselves. And as part of that is we're obligated to see anybody who comes into our door. So as a not-for-profit organization, anybody that comes into our organization, we treat, regardless of their ability to pay, which will be relevant when I talk about the one big beautiful bill. We have more than 1,500 employees, about 190 physicians, and we're still doing OB. That's the other thing I'd like to point out. One of the things that Don, you talked to me about before was the impact of one big beautiful bill. And Medi-Cal is under a lot of pressure from the federal government, and I think it's over 70% of our deliveries are covered by the Medi-Cal program. And a lot of small organizations have chosen to give up that service. There are things called OB deserts out there in the world where women just cannot get access to labor and delivery care. And I'm really proud to say that Marshall keeps pinching our pennies and moving the money around so that we can continue to afford to be able to provide that necessary care for women. And we deliver about right around 350 babies a year. So one of the things we love to get out there is choose Marshall for your OB care, because we know there are women who are going out of county for their care. And some of that's insurance driven, but some of it's also choice. And so, we have a great program with doulas and certified nurse midwives, and we really going back to listening to our patients. That's one of the areas where we strive really hard to meet people where they're at. What's your birth plan? How can we help you get what you need? And then back it up with all of the medical stuff that you need to in case something happens. 63,000 patients roughly in fiscal year 24. So there's that. So a little bit about our economic impact. So you didn't ask me about this, but I'm going to share it with you anyway. We produce about 5.4 billion of economic output. That's over, I think, 10 years. So what does that mean? That means that the money that Marshall pays our employees, that we spend on vendors, that we buy supplies, that economic benefit ripples out through the economy and creates 5.4 billion of economic output. So all the doctors that work at Marshall buy homes, buy groceries, go out to restaurants, their kids go to schools, their kids are in activities, all of that creates that economic engine. I wasn't going to spend any questions about that before I go on. I wasn't going to spend a whole lot of time on this slide.
Go
Nope.
for it.
Okay. I'm going to keep going. So our payer mix, I talked about that a little bit. So 14% of our business is covered by Medi-Cal. So Medicaid is what they call it in every other state. In California, we call it Medi-Cal. 60% of our patients are covered by Medicare programs. So 65 and above, Medicare pays for those. Those are very vulnerable people. There is a lack of access for care, especially if you have Medi-Cal, where specialists don't always get incentivized to see you, and it's very difficult sometimes to get care. Medi-Cal is one of those things that is under fire by the One Big Beautiful Bill, and I'll go into a little bit of the technical of why. But Marshall is not alone. The point of that next bullet point is that 37% of the hospitals are operating the red in the country, and 34% of them, rural hospitals are actually at risk of closing. And it's not a day goes by that I don't get information from either Becker's or Modern Healthcare or AHA about hospitals closing programs, laying people off, or closing abruptly. There was one recently. Gosh, I wish I could remember where it was from. It was in California. I can't remember exactly where it was from. But if they didn't get a loan by, I think it was last Friday, they were going to close. Like, boom, January 10th was their last day of operations. And so
Wow.
there's a lot of hospitals that are really hanging by a thread, and it's a very tenuous environment out in the world right now.
Yep.
So can I ask, there's a couple of things I'm tracking that are sort of related to that, and one is the impact of the seismic requirements on Marshall, and the other is the sales tax proposal. And how does the one hurt and how will the other one help?
Well, I will get to that. I
Oh,
100%
it's
will
in
get to that.
here.
I am
Okay.
getting there. Yeah. So unfunded mandates are my favorite thing to talk about. So there's
Okay.
that. Marshall is not alone. I guess my point of all of this is Marshall is not alone. And, we're not, okay, let me just dispel rumors because I put slides out here like this and then people think, oh my God. So Marshall's not going to close. We're not going to go bankrupt. We're not going to sell to Dignity, Sutter, Kaiser, Adventist, whoever else you think might be out there in the world trying to buy us. We're not doing any of that. And is it tough? Yeah, it's tough out there right now. But we're doing what Marshall has always done, which is be scrappy and be smart and be thoughtful about where we invest so that we can be here for the long run. So this is not unusual for Marshall, but the universe around us has definitely gotten a lot tougher. So that goes back to your earlier question. Um, so HR1, also known as One Big Beautiful Bill, there's a couple of big issues with HR1, and then I'll get to seismic and the tax stuff. So HR1 was really two big things that impacted healthcare and specifically Medi-Cal. The first thing I'm going to say is the One Big Beautiful Bill was a tax bill. It was not a policy bill. The way they paid for it might have been out of healthcare, but it was not a policy bill. It was a tax bill. So, based on how they rolled it out, because of the Medi-Cal redetermination starting January of 27, people who are on Medi-Cal are going to have to reapply. I think it's every 30 or 60 days, maybe 60 days. Now, when we had COVID, and they had those continuing resolutions. Once you were on Medi-Cal, you didn't have to continuously reapply. But this means they're going to make it harder for people to stay on Medi-Cal. And then there's also a lot of, I'm sure you guys have heard, a lot of issues with extending Medi-Cal benefits to the undocumented. And so the federal government has told states like California that if you are allowing the Medi-Cal program or the Medicaid program to provide care or coverage for people who are undocumented, then there's going to be financial consequences for the states. So I believe the state of California has started to roll some of that back, which means less people are going to have access to coverage. Like I said, we're still going to see people that come into our emergency department as a not-for-profit organization. That's our goal. That's what we do. The other big part of HR1 was, and I'm sure if you've read some of the news, it's the impact of provider taxes or fee programs. Does that sound familiar to anybody?
Not me.
Not sure.
So I'm going to give you the highlights and then you can ask me questions later. So 49 states in the country have what they call a Medi-Cal fee program or a state fee program or a provider tax program. They go by a couple different names. And essentially what it is a state will tax providers, hospitals,
Right.
and then use that money to draw down federal money. So the federal government has put a lot of hurdles in front of us. So right now, the Medi-Cal fee program for California is at risk. And that number is anywhere from $5 to $8 billion a year to the state. So the state of California is currently in negotiations with CMS, which is the Center for Medicare and Medicaid Services, the one that runs the Medicare program, that is taking direction from HR1 and having negotiations about this provider tax program in the state of California. We're not the only state that's having this challenge, but right now it's a major source of concern for the state. So I'm going to stop there and see if you guys have questions about that.
Yeah, I'm wondering, can you just explain that to me again? So they tax you, they tax Marshall, and then how do they get at the federal dollars?
So there's a program in the federal government that says the state uses that for their general fund obligation. So Medi-Cal in the California is paid roughly 50% by the state and 50% by the federal government. So every dollar of Medi-Cal costs the state 50 cents and costs the federal government 50 cents. So when they tax the providers, the state uses that as their 50%. Right? They say, oh, look, here's our tax revenue, which we're going to spend on healthcare. And then the federal government kicks in their 50%. Does that make sense?
That does make sense. And so what's at risk here is the federal government's 50% contribution?
Well, the whole program is at risk right now. Right. Because it's the state of California, because the math gets really wonky. The state of California actually makes money off of this program, and it's about $1.5 billion for the state. The State of the Union came out. I know Gavin Newsom said everything was great. I've heard numbers that there is a state budget deficit. So I don't know. I don't live at the state, but who knows? But it is almost a $2 billion number for the state of California because they get some fees for administering the whole program. So it's a big issue across the state, and hospitals like Marshall get millions of dollars from this program every year. And it started in 2009. And so since then, it's been a very stable program until HR1 or One Big Beautiful Bill sort of changed the rules on everybody sort of midstream, and everybody's sort of reacting to that.
So,
That's helpful. Thank you.
so what I'm hearing is they've put limits on how much you can collect in taxes, which that would then affect the matching part that the federal government gives.
They did that, and they also said, we don't like the way California decides to spend the money. So there's taxing rules, and then there's how you use the money rules. And so the state of California put in for money, the taxing rule, the tax, according to them, they think it's too high, the Fed being they in this situation.
Okay.
And there's some specifics in the California program, which they don't like on how it's being allocated back out. So there's the
So-
taxing issue and the spending issue.
So
States' rights, right?
as far as the spending, is the Fed's major objection around illegal immigration, or are there other issues?
No, it gets really technical really fast, but it has to go with things like, well, that's on the tax side. On the distribution side, they want it to be, so in the state of California and every state, they tax it at one rate and there's winners and losers, right? So they don't like to hold harmless so that anybody who's a loser gets their bucket filled back up again. So that's one of the things they didn't like, was that whole harmless provision. It gets really complicated. I could have you guys like go for days on it, but whatever.
Okay.
I know. And I learn about
Next
it all
meeting.
the time. Yeah, I know. I'll give you a whole story on Medi-Cal fee programs.
Okay.
So and so that is actually a potential direct impact to Marshall. Like I said, we are net positive. We get money from the Medi-Cal fee program, and it is multiple millions of dollars for us. And so we are watching this one very closely. So this one is a little bit more to your question, Dawn, about the tax and the fire issue, what's going on. So let me see. Let me just spend a minute. I'll stop here and talk about seismic, because let's just talk about seismic. I don't know if I have an actual slide in for seismic,
Bye-bye.
but I'll put it in here anyway. 1994 Northridge earthquake. Everybody remember that one?
Yep.
Lived
Right.
through it, was
Yeah,
there.
so it was a thing. So one of the things the state did is mandate that all hospitals in the state of California have to meet certain seismic safety standards. Those standards are uniform across every single hospital in the state of California, regardless of whether you are in an earthquake-prone area or not.
Right.
They are uniform whether you are in a single-story wood frame critical access hospital or a multi-story skyscraper in downtown Oakland. They are the exact same standards,
Wow.
which is really, like I said, it's not about policy,
Um,
right? It's not about policy. That's part of it. And then the rules just kept getting tougher. So Marshall meets the 2020 earthquake standards, which is essentially safe and standing. So the building is not going to collapse if we have an earthquake in El Dorado County. It isn't. What we need to do is invest money to meet the 2030 standards, which is things like bracing inside the walls so that the pipes for the water don't wiggle around. One of my favorite parts of the 2030 standards is that
Yes.
all hospitals in the state of California
Four and a half
have to
minutes left,
have,
and we're on the 8-yard line. We score now.
oh,
Hey, Greg, not
Oh,
on mute.
sorry.
that's all right. Hi, Greg. How's the Niners doing, buddy? Let's see how they're doing.
Seriously? Okay, they are down 19-17, 4 minutes left, and they're on the 8-yard line, which leaves them Philadelphia too much time to come back and beat them. So I'm kind of concerned.
All
But go
right.
They'll be
ahead, I'm
fine.
listening.
They'll be fine. Go
Believe it or
Niners.
not.
Okay. So things like, so my favorite part of the 2030 standards is that all hospitals have to have 3 days worth of water, wastewater storage, fuel, food, and fuel storage. Because in case Placerville can't provide water to us, we have to be an island unto ourselves and be able to operate for 3 days.
Mm.
Right. Right. So it does not really matter whether it's a risk for us or not. And you pointed out, Don, fire is a much bigger risk for us.
Right.
Fire is a much bigger risk in El Dorado County than earthquakes are. We have little ones up in the basin, but they kind of rumble, and there's
Yeah.
nothing big, right? But fire is a much bigger risk. So I'll go back to my slide. So our emergency room is there 24/7, 365. We do about 34,000 emergency room visits every day. So part of let me see if it's on the next slide.
34,000?
34,000 ED visits every year.
Oh, yeah, okay.
Every year. Sorry, did I say a different day? Sorry.
Yeah.
Sorry. Every year, 34,000 every year. It's around 100 a day. It's a lot. It's a very busy emergency department. It's a very busy emergency department. And then we do backup. If somebody can't get care, we're the backup. If somebody is a senior living at home and their family just figures out that they can't take care of them anymore, where do they take them? They take them to the emergency department. And then we figure out how to safely discharge this patient and get them into a skilled nursing facility, which is probably what they need, but the family can't do it. And so we end up being the backstop for a lot of care. We have patients in skilled nursing facility that come to us for care, and then we try and get them back. And sometimes they take them, and sometimes they don't. So it's a very we're here as the backdrop, as the backstop for care in El Dorado County. That is our job. Let me see. So one of the things we're doing is we are investing in El Dorado Hills. So I'm sure you guys have seen our new clinic down there. So my contention as the CEO of this organization is that I firmly believe, I'm a former CFO, by the way, I'm a CPA, fully vetted in finance stuff. You cannot cut your way out of problems. You have to grow your way out of problems. And that's what Marshall's working on. That's what our investment is in El Dorado Hills, that 25,000 square foot clinic, which hopefully you guys have seen about. That is an investment in expanding access to care, but it's also a way for us to get at that growing population in Western El Dorado County to help support all the work we're doing up the hill further in Georgetown, in Placerville, in Cameron Park. All those things are connected. And so that's an example of us growing our care. Another one is we added a second MRI down in our Cameron Park location. So that we have 2 MRIs now. We're going to replace the one, and we have a mobile that's running now while we're waiting to replace the second one. And that's an example of growing our way out of our problem. Patients need MRIs. We can add that and expand access to care. And it helps us meet our financial goals because we have to have enough money to invest in things. Christy.
This is kind of an aside. I live in Georgetown. I'm really interested in what modernization you might have for the clinic up here.
Yeah, actually, that's what on our plans. We're really working hard on Georgetown to figure out, well, we did finally paint it, so that was good. And Georgetown is unique because it's a rural health center. It's a rural health center, and so it's the payment rules are a little bit different. And so our long-term plan is to expand access to care in Georgetown, whether it would be in that same location or not, if there's a way to grow in that current location, or if we'd have to look for something else, that is TBD. But I think there's a way to add more exam rooms up there, create better care or more care up there. And so definitely committed to the Georgetown community.
Thank you.
Yeah, well, it's an important part of what we do, right? And we do all kinds of outreach up there. We did the health fair up there. We did a lot trying to get women to get mammograms up there. One of the things I'm really proud about is that probably, I think the last time I saw the numbers, 80% of the women we serve have gotten the mammograms that they need. And that statistic is probably double what the national average is. On average, only 40% of women are getting the mammograms that they need. So I see a lot of women on this group. Go get your mammograms. Go get your mammograms and get your colonoscopies. It matters. Get that preventative care. It really does matter. So that outreach really is part of who we are as an organization. Okay, I think that was the end of my slides. So let me stop sharing, and then I can talk to you guys about the sales tax initiative. So this was started, I think it's called El Dorado Ready. I think it's what it's called, El Dorado Ready. It is currently, where are we now in the process? I think the language has been submitted to the County Board of Supervisors, the county clerk, county attorney, somebody at the county has to review the language. And then once they give us their summary of the language, the next step is to go out and gather signatures for a citizens initiative. The intention is this would be a citizens initiative, and it's really intended to do a couple of things. One is fire, because I talked earlier about fire. So fire prevention, fire care, fire access to resources, fire all across all of El Dorado County, and then access to medical care as well. So emergency care, modernizing facilities, and all those kinds of things. So it's a connection to fire and care. And that's the intention. I don't have the language in front of me, but I'm doing this from memory. It is a citizens initiative, so Marshall is very supportive of it, as are a lot of the fire chiefs. But we are collaborating a lot with partners around the initiative. And I think it, like I said, it's called El Dorado Ready. So did that help, Don?
Yeah. I actually came to the board I'm on last month for support, and we kind of threw it back because we wanted to see the final language first.
Yeah.
But it's well known that the Cameron Park CSD has had trouble affording our fire department, so I am pretty sure that once it's finalized and we fully understand it, we're gonna support it because it's definitely gonna help us.
Well, thank you. And we worked really hard to build those coalitions with local communities and the fire guys, because I live in El Dorado County. I care about fire. I mean, we all saw the devastation of the Camp Fire, and it was close. The Tahoe Basin, almost in the Caldor fire, was
Caldor, yeah.
yeah, it was close. It like leaped over Christmas Valley, right? And it could have been, I mean, as horrible as it was, but it could have been a lot worse. And so I have to say, I know I feel bad for everybody impacted by fire, but I do feel, I don't know what the right word is. When I hear a lot about the devastation of the fires in Southern California, what I kind of want to say is we've been here having the same problem for decades. Like where you been? I know that's not a popular thing to say,
Well,
but I mean,
and
I feel
there've
bad
been,
for anybody impacted by
yeah,
fire. I really do.
but there've been major fires in Southern California as long as I've been alive, and I lived down there until about 20 years ago. But and it's definitely probably worse up here. But so Laura, you have a question?
Yeah, thank you. So sorry, I'm new to this group. So Dawn, when you said we will support this, does that mean this group will support it? Who's the we?
No. So
referring?
I'm an elected board member on the Cameron Park Community Services District, and while I obviously cannot say what the board's gonna do, it does appear that the board will, once we have the final language, support the initiative because we have a fire department in Cameron Park that we're responsible for, and this will help us.
And what is the likelihood that the Board of Supervisors is going to support it? Do we know that yet?
I I couldn't say, but I know the Taxpayers Association is already out there not being happy about it, but they're not happy about any kind of a tax increase about anything.
Right.
My personal opinion is that is specifically as far as the part that directly helps fire, this is much more likely to pass in El Dorado County than a ballot initiative that's fire district specific. Every single fire ballot initiative that I am aware of in like the last 20 years has gone down in flames. So this sounds much less hard on people's purse strings. It impacts money spent by tourists, not just people in
Right.
El Dorado County. And so I'm hopeful that this one will fly through because our fire departments do not get enough money for what they are expected to do, not just Cameron Park, but the entire county.
Yeah. And it's a proposed 3/8 cent sales tax. I should have said that in there. And so you're
Uh-huh.
right, Don. Part of that was to try and, because we get a lot of visitors in El Dorado County, which is great, but they can help pay for some of the infrastructure that we need, right? Because they use the infrastructure. So it seemed like the
Yep.
more fair way to go after it.
What was
But
that?
we should
number?
get, sorry, we should get the language from the county after they do whatever it is they're supposed to do. I think the end of the month, beginning of February, something like that. It's called a title and summary for anybody who knows this stuff. Not a politician. Not a
No,
politician.
not really a
Mm.
politician either.
Not a
Um,
politician.
Do we have any other questions, or was that the end of your slides, or
That was the end of my slides.
that
Yes, thank you.
was? Okay, so
I have a question.
go
Sure.
for it.
Um, I missed whether this was a sales tax or a use tax on hotel rentals and what else?
It's designed as a sales tax.
Okay. I think, one of the things people keep on forgetting is that we drive down the hill and spend our money. If they would allow some growth here, we wouldn't be spending the money on gasoline to go down to the valley and give them our tax money.
Mhm.
Much rather have it spent up here to support the needs of the community.
Yep, buy local. You're speaking my language. I tell that to people all the time on healthcare. Everybody thinks buy local means go to the local store on Down Street, Main Street, Placerville, and buy something. Well, sometimes it means bigger than that. Sometimes it's like, hey, make sure your health insurance will cover Marshall and pick Marshall, because that does help. I mean, we're like I said, we're part of this community. We try and use local vendors. We've used Carter Kelly for decades to help with our construction projects. We really work hard with local vendors as much as we possibly can. And part of that is not being part of a big system. Because I will tell you, I've spent lots of time in my career in big health systems where they have these giant national contracts. And, I would say things like, hey, I live in a rural community. It'd be really nice to buy a local vendor. Yeah, no, we're not doing that. Because the price may be slightly different. But I think it's really important to support that local economy, to your point, Chris.
For sure. Okay, does anybody else? Maureen
Looks
has
like
a hand.
Maureen does.
Maureen
Yep.
has a literal hand up.
Yes, well, it's now at one of your slides, and my voice wasn't on and I didn't get to raise my hand in time. You mentioned that the HR1 bill was going to have an impact on Medicare. And I'm a Medicare patient at Marshall. And I'm wondering what do you think that impact is going to be on Medicare?
So it mostly targeted Medi-Cal. If I said Medicare, I misspoke. It mostly targeted the Medi-Cal or Medicaid programs. You might have been thinking about the Center for Medicare and Medicaid Services, who oversees both Medicare and Medi-Cal. And so I did talk about them, but HR1 was really using the money from the Medi-Cal, the federal part of the Medi-Cal program, to pay for a lot of the things that HR1 did.
Okay.
And like I said, in California, it's called Medi-Cal. The rest of the country calls it Medicaid.
Well, some states have other names too, but
Yeah.
yes,
But it's generally the federal government
General.
calls it Medicaid.
right.
Yep.
Just wondering.
Sorry. Yeah, I haven't heard of big impacts. What I will say is they've also talked about other reconciliation bills that would go after the Medicare program. But I think, given the fact that there was 16 Republicans voted to extend the ACA subsidies. I think they're kind
17.
of, was it 17? I don't know. I
Yeah.
just read the news. I think they're sort of thinking, well, maybe we just let it lie for a little bit until after the midterm elections, but who knows? I
Right.
am not a politician.
So I work for a really large health insurance company. Used to work for Health Net and Blue Shield and some others, and then Centene came in and bought Health Net. I work in their IT department. And one of the things that hit this autumn, thanks to this wonderful bill, was they pulled out of a lot of markets. And I'm just wondering if the impact on Medicaid and Medi-Cal is going to clobber the insurance companies.
I don't know yet. I think they pulled out of Medicare Advantage markets. So we did have a
Uh-huh.
couple of insurers pull out of Dorado County that were MA or Medicare Advantage plans. So for people who want to have a better understanding of what I'm talking about, there's a couple of different, when you sign up for Medicare, you can just get straight old fee for service Medicare and you pay whatever your Part B premium is, right? So depending on how much money you make, that's how much you have to chip in for your Part B premium. And then Or you can do a MA plan or Medicare Advantage plan. So companies like Centene will say, hey, we'll cover Part B for you at no cost, but you have to use our network. So it's a narrow network. I don't know if Centene does it. I just did that because that's who you said you work for. So it was a
They
name.
probably do.
Yeah,
I'm
and
not,
so you say they narrow the network and they'll say, we'll give you a very small premium or no premium, and we'll cover everything. I will say that from a provider side of the universe, Medicare Advantage plans, generally what they do, Medicare will pay you 100% of the Medicare fee schedule. Like they'll just pay you 100% of that Medicare fee schedule. So there's a fee schedule that says for this service, you're going to get paid this amount of money. It's a little more complicated than that, but basically that's how it works.
Right.
The MA plans say they're going to pay you 115% or 108% of the Medicare fee schedule. And then you say, oh, that sounds great. We get a little bit more money. That sounds awesome. But then what they do is they deny everything.
Right.
So your net money is actually usually 60% or 70% of the Medi-Cal fee schedule. So organizations like Marshall, we do have a couple of Medicare Advantage plans, but they are not paying what straight up Medicare pays us because of all the
Interesting.
denials. And then what they do
Okay.
is they deny things, and then we have to spend massive amounts of time and resources to argue the denial, and
Right.
then we may or may not get paid.
Yeah,
We may or
the
may not.
whole
I mean, we
appeal
provided the
process,
service. We
yeah.
said, here's a contract. We should get paid $1,500 or whatever, 15,000, whatever the number is. And then
Yeah.
they come back and go, no, we're not paying for it.
Yep.
It's kind of ironic because the people who oppose socialized medicine consider it rationing medical care, but it's really that's what the insurance companies are doing.
They are.
So Laura, you have a question? Hand raised?
Yeah, I did. I'm curious, as operating as a nonprofit, are you able to attract and keep doctors and nurses and other staff? Do you pay competitively to keep people?
Yeah, great question. We have to, right? Because to your point, if we didn't, we wouldn't get anybody. So we have surveys that we do. We look at many different wage and surveys out there in the world for physicians. We look at, we have companies that come out and do us and tell us the fair market value rate for this specialty is whatever the number is. And we are making sure that we're being competitive with wages and benefits. I will say we have very generous benefits at Marshall because if we don't, we won't be able to attract and retain employees and providers. We work really hard to create a great culture, but if you can get a 50% raise somewhere else, people are willing to trade off culture. You have to be a great culture that pays in the ballpark. We don't have to be matching people, but we have to be in the ballpark and have that great culture where people know that they're listened to, that they're valued, that we care what they think, and we work with our employees. Did
Thank
that
you.
answer your question?
Yeah, absolutely. Thank you.
Yeah, because we have to. I mean, if we can't just say, oh, we're not for profit, we're going to pay 15% of what everybody else does. We'd never get anybody to come work for us. We'd never happen.
Yeah.
But that was a
Okay.
great question. Thank you.
Does anybody else have any questions? Yes, Lorraine.
I do. So I'm just curious, are you being asked to go speak to any Republican groups or chambers
yeah.
of commerce or anything regarding the bill? And if so, what is their response to the impacts that's going to hurt our whole community?
I share information and I let people draw their own conclusions. I am just sharing facts with everybody, and I'm happy to. We actually talked to the Taxpayer Association in El Dorado County. Like I speak at chambers. If you guys think there's another group I should go talk to, I'm more than happy to do that. I just share information. I let people draw their own conclusions.
But what's their response? Are they concerned or are they thinking great because we'll be paying less in taxes or?
I think it's all over the map. I think it's all over the map. People are all, I understand that tax burdens are hard. I totally get that. And I think it's right that we should be careful about how we spend tax money. 100% we need to be careful about it because it is an obligation to the people who are paying that we're good and fruitful and frugal with tax money. I I stay out of the politics side of all this.
Okay.
I just, I can't. I can't.
All
But I'm
right.
happy to talk to any group. I'm happy to. And I,
think you've
like I said,
got
I
'em.
know Dawn's asking for questions, but I just want to say once again, we're getting close to
Mhm.
time. How much
Yeah,
I
we are.
appreciate you guys letting me talk to you today.
We really appreciate you
great.
coming.
Yes.
How's the game, Greg? That's what I really want to know.
Niners won
Oh,
23 to 19.
Hey,
Wow.
my son was a giant 49er fan, so everybody think about Billy when
All right,
think about the
Billy.
49ers. Yeah.
Thank you.
Okay.
Yeah. Thank you. I'm very happy.
Great
All right.
presentation.
Well,
All right. Well,
you
thank
so
you guys so
much.
much. Thank you, Dawn, for the text, and thank you guys for the time. And I'm happy to chat with, if you guys have other groups you belong to, you think it'd be good to have me come and talk to them, happy to do that.
Okay.
So there's
awesome.
another a comment in the chat thanking you.
Oh, there's a chat. Let me look.
Right.
That's a
We do
private.
have a
Okay.
person without a microphone, so
Thank you so much for spending your time with us to give us great info. You're more than, I'm happy to anytime. You guys just let me know.
Yeah,
okay.
it was great.
Much
Thank you.
appreciated.
All right.
So, if there are no further questions and no other announcements, I am going to call the meeting adjourned and thank you everybody for coming.
Thank
I
you.
am going to share the recording once I figure out how to get it to our YouTube channel. It will be available. So if you have anybody who's interested that you want to share it with, look for it on our Facebook and probably in our newsletter in a couple of days. It shouldn't take me that long. And thanks everybody for coming. Much appreciated.
Thank you,
Thank
Don.
you. Go Niners.
Thank you
Yeah.
all.
Go Niners.